Good evening, good afternoon. Um, I want to thank everyone for visiting us again. I'm Keith Crawford. I'm the Director of Clinical Trials and Patient Education at Prostate Health Education Network. Um, Today, we're very interesting, in a second, um, topic. And it's something that the way the title was written, it was about how you feel. So this title for managing survivorship is, ah, it's back. So what do you do when prostate cancer returns? And we said it like that because that's how we feel. We had surgery, we had radiation, we had some form of treatment, and then it's back. So we have a guest speaker, Dr. Mark Pomerantz, a medical oncologist from the Dana-Farber Cancer Institute. And I already introduced myself. I'm Keith Crawford. So I want to take some time. One thing I want to do, Jerry, is can we put up our survey? Because we'd like to know every time we introduce a topic, we want to understand how much you know about the topic and how well we're able to bring awareness to this topic. So we want input from not only the survivors, even people who are recently diagnosed, caregivers, advocacy or groups, and anyone who has, it's important for them to understand what happens when you're receiving prostate cancer treatment. So, Jerry, you're going to put the survey questions up.
Yes, it's up.
Okay. The first thing that I'm going to do is PHIN, Prostate Health Education Network, was founded by Tom Farrington. He is a 26-year prostate cancer survivor, and it's based upon the journey of a prostate cancer patient. One of the most important things for a prostate cancer patient is what treatment options? What are the treatment options that are available to me and how do I select them? So the first thing we wanted to do is this. So PHIN creates tools for all men along their prostate cancer journey. PHIN PSA focuses on early detection screening. And it's important for all in the audience to recognize there has been a change, and we focus on NCCN guidelines. And those guidelines state that screening for high-risk individuals should begin at age 40. Next, then you're being diagnosed with prostate cancer. Between the time you're diagnosed and the time you start receiving treatment, it could be 2 weeks, it could be a month. And some people take a lot of time to figure out what their treatment options are going to be. So it could be months. But instead of you going to Dr. Google, what we have at finpath.com are the treatment options that are available, that are the guidelines for from NCCN. Okay. What we have here is FinPath. FinPath is based upon the guidelines, the National Comprehensive Cancer Network guidelines. And so what we've done is taken those guidelines and taken them from a very complicated state and brought it down so the average person can understand it. Now, this portal, FinPath, is not an app. So you don't have to give your information or pay or do anything like that. You can have it on your phone. You can have it on a tablet. So when you go into and meet with your clinician, your healthcare provider, you can talk about NCCN guidelines as it relates to treatments. Okay, so that's the same thing for early detection. If you're initially diagnosed, Or in this case, what we're talking about is recurrence. It's back. So you could primarily, you either have radiation or surgery. So if the disease comes back, whether it's radiation or surgery, there are treatment options that are available. So if we look at PSA recurrence after surgery, now, and they separate it into two categories, whether or not the disease has come back, prostate cancer has come back, and it's localized to the area of the prostate, or it has moved away from the area of the prostate, metastasis, moving away. And if you notice, as I'm showing here, that if it's localized, they look at your life expectancy, and you could have external beam radiation, or you could monitor it, or you could have external beam radiation plus a antigen deprivation therapy or a next generation therapy. Now, if it's moved around, moved away from the location, then you will have ADT, you can have chemotherapy. But again, the point is that these are the treatment options that are available. You don't have to go to Dr. Google to find out. You have a reliable source that physicians will follow in your treatment. So we talk about the recurrence after surgery or after treatment of radiation. Similar concept is the disease localized in a local area of where the prostate is, or if it's moved away. In any one of these situations, there are treatment options that are available that clinicians are going to follow. And these are their guidelines. Now, just a reminder, to get more information about this is at your fingertips, and that's finpath.com. Now, what I want to do is I want to stop here, and I'm going to stop sharing, and I want to bring on our guest. We're not trying to, it's not a class. We want you to feel like you can have a discussion and with a clinician, someone who is responsible for helping you make that treatment decision when the cancer comes back. And that's Dr. Mark Pomerantz. Mark, are you there?
I'm here. Hopefully you can hear me.
Yes. Thank you again. I know you're busy, but thank you for taking the time on a Wednesday.
It's always an honor to participate in FEN activities and presentations.
Well, thank you very much. And we had a little bit of traffic problems because the Sox were playing. But
that's right.
They did win. I just want everybody to know. Okay. So what I wanted to do, Mark, is help me understand. The first thing is when you're diagnosed with prostate cancer and then the cancer comes back, what does that mean when the cancer comes back?
It's a fantastic question. It's an almost philosophical question, but I can tell you what we know. When we say that the cancer comes back, it means that even though we tried to cure the cancer, usually with surgery or with radiation, and we have acquired evidence that the prostate cancer still exists. And this is an opportunity to talk a little bit about PSA, because this is what PSA was built for. We first meet PSA and the PSA blood test as a screening tool before with your primary care doctor or your urologist before you're diagnosed with prostate cancer. But PSA is famously an imperfect screening tool. It's got all kinds of problems as a screening tool. It's the best we've got, and we lean on it, but it's got serious limitations. As a marker for cancer that may have come back after treatment, It's one of the best blood tests we have in the entire world of oncology. It's very reliable. And in just about all cases, that's the first signal that we get after treatment is that blood test that there are cancer cells somewhere in the body that did not get killed with upfront surgery or radiation.
Mhm. So does raising, so what you're saying PSA, prostate specific antigen, right?
Mhm.
Um, is it more sensitive during the recurrent stage?
Yeah.
Does it always mean the same thing? Maybe that's what I'm thinking about.
Yeah. In the recurrent stage, there's less noise from the normal prostate tissue. One of the reasons that it's so difficult to really interpret the PSA when we're getting screened for prostate cancer before the diagnosis is that there's a lot of noise being made by the normal prostate tissue that also makes PSA. After treatment, that noise goes away. The entire signal is coming from cancer in the months and even years after treatment. So we can really rely on that blood marker as a signal that there are cancer cells that have not yet been eradicated.
Okay. So you said noise. So it's not, PSA is not produced by any other tissue in the body other than the prostate, right?
That is correct, but it does not distinguish between normal, healthy prostate tissue and tumor prostate tissue, prostate cancer.
Okay. Okay. So then the noise is down compared to when it's early when you're screening.
Right.
So when you are sitting in the office and you're meeting with a patient, when you tell them it's back, how do you get the patient to handle that? How do you comfort the patient? Because the first thing that happens is that's just like the first time you hear you have cancer, and then the next thing is it's back. Patients don't hear anything anymore, and it's like,
Yeah,
oh, they give up sometimes.
it's heavy. And for patients that are out there listening to this, this is why it's always important to the oncology team, whenever possible, that you bring someone you trust along with you to the clinic visit. Because a lot of the information that we have to impart is difficult for any single human to completely absorb and process. It's always helpful to have someone with you that you trust. That said, this is the toughest part of our job in oncology is delivering bad news and news that we still have work to do. Um, we all, whenever we have a medical procedure, we're always told the pros and cons and the knowns and the unknowns and the risks. And we all know that there are no guarantees in life and certainly in biology or in medicine. But it does hit very hard when you go through everything one goes through to try and cure a prostate cancer and find out that it's not cured.
Right. So our take-home message, just right here when we start talking about recurrence, is, well, let me backtrack. How often should we be evaluating our PSA? So
Yeah.
after you have your treatment,
Mhm.
and is it what, every year, every 3 months, every 6 months, or how long, and for what period of time should we be monitoring that?
It's a very good question. And there really are two paths, one for our surgery patients and one for our radiation patients. Um, for our surgery patients, it's actually much easier to evaluate the PSA because there's no prostate tissue left in the body. And the PSA should be zero post-surgery. And when we check the PSA, either it's at the undetectable range or it's not zero, and it suggests that there's disease still in the body. We recommend getting a PSA check about 6 to 8 weeks after surgery to make sure that it's gone down to the undetectable range. And then for the first couple of years, I recommend, everyone does it slightly differently, but I recommend checking every 3 months for the first couple of years. And then we can begin to spread it out to every 6 months. And when we get to the 3-year mark, we can check yearly. But it is a lifelong thing because even though the risk of there being disease left behind decreases with time, it never goes down to zero. So eventually we are checking yearly for life. And the rules are slightly different for our radiation patients, which I can go into if you can tolerate my continuing to talk.
We have time.
Okay.
And we do have there's some folks here who are deciding on their treatment and also have had radiation treatment.
Yes.
So if we can dig into this a little bit more.
Oh, good. So post-surgery, it's straightforward, a little bit more straightforward as I just described. For our radiation patients, it's a little bit more complicated because there's still prostate tissue left in the body. The prostate tissue did not get removed. It just got terribly sunburnt. And eventually that normal prostate tissue will recover and start making a little PSA. So I still recommend the same timetable of PSAs every 3 months for the first couple of years, then every 6 months for a couple of years, and then yearly. But the PSA patterns are a little bit different with the radiation patients than with the surgery patients. Over time, we do expect the PSA to trickle up a little bit as that normal prostate tissue recovers, but it should plateau somewhere below 2.0 because the normal prostate tissue will then grow to a size that you'll have for life. If there's cancer left behind, the PSA starts to do its little rise and then just keeps rising past 2.0. And that's what we're monitoring for when we check the serial PSAs.
Okay. So let me just see. If you have surgery, your PSA should be 0. Or
no test is perfect. So there's always can be a little noise in the machine, but it should definitely be accounting for the noise in the machine. It should be below 0.1.
And so it's below 0.1. But then we go to radiation. First thing, radiation doesn't bring it down to 0.
Sometimes it does, sometimes it doesn't.
Okay. But then it may creep up and have a baseline level of 2.
Yeah, as high as 2. Most men's baseline post-radiation is around 1 or a little bit less. But the official rule that we made up that tends to work in practice is if the PSA makes it to 2, we declare that to be a recurrence of the prostate cancer.
And so if it gets to 2, and you're going to treat it again. You begin treating.
It means we have more work to do.
Okay. Now, what's interesting, if it starts to creep up in after surgery, then
we pounce much sooner than that.
Okay.
We don't wait for it to go to 2, and I'm happy to talk about what we do.
Talk about this,
but I don't want to get ahead of you.
No, this is critical because now you've just transitioned to what to do next.
Right.
Right. So help us understand this right here. So you got the prostate, you've had surgery. We're not going to wait until the PSA level gets to 2. So what do you do? Tell me your thought process. Yeah. So, all those patients out there have an idea of what to be looking for.
And this is a very common clinical scenario. This is a very common problem that we face in our clinic. Are patients whose PSA post-surgery is becoming detectable. We have learned over decades now of observing and treating the situation that the vast majority of the time, that PSA is coming from residual, rogue, remaining prostate cancer cells in the old neighborhood. They are typically in the area of the prostate or nearby, somewhere nearby in the pelvis. That just tends to be where the bad guys are still hiding out. We can't see them. We don't have the technology to see them. Our scans are not good enough to see them. When the PSA becomes detectable, these cells are still microscopic. The only reason we know they're there is because the PSA is going up. And the only reason we know that the most likely place for them to be is near the prostate bed where the surgery happened, or in the lymph nodes in the pelvis nearby. The only reason we know that is from experience. But because we know that, we get a second crack at them after the surgery. We can mop up the area with radiation. And we've been doing that for a long, long time.
So after surgery, you can mop it up. You can go after that area where the probability is the prostate is located. I mean, the cancer is located with radiation. That's that external beam radiation.
It has to be external beam radiation because it's that type of radiation that allows us to cast a wide net. Because we don't know where these cells are. We just have to make an educated guess as to where they are. So we cast as wide a net as we safely can and try and mop up what's left behind.
So now let's stop there. So we have radiation treatment. Now it's interesting. So radiation treatment by itself?
Oh, I'm glad you asked.
Oh, okay. Okay.
No, that was the right segment. It was the perfect segment. It was as if we rehearsed.
That's my question too.
The people, I had that look from people in the audience. They said, like, well, is that it? Is that it? I said, so I'm letting you know they're listening. They're leaning forward.
Okay. You asked exactly the right question. Is that it? And that's a question that we've been asking over the past several years. And because we know that hormonal therapy, taking away a guy's testosterone, taking advantage of this incredible Achilles heel that prostate cancer has, that hormonal therapy does make radiation work better. We've known that now for a long, long time, for more than 20 years. And so we ask the question, if hormonal therapy makes the radiation work better, does it make this type of radiation work better when we're trying to mop things up? And I'll give the mopping up a name. We call it salvage radiation therapy. Does the hormonal therapy make the salvage radiation therapy work better? And we have a few trials that suggest that it does. A very important trial that was published within the past 18 months tried to figure out how much hormonal therapy do we need, and does every single patient need hormonal therapy? And it turns it. Oh, I'm sorry.
No. I was saying. Okay, we're sitting. Okay. The edge of the seat, trying to figure out.
Yes. So it turns out that there are some prostate cancers that are so easily cured with the mop-up that they do not need hormonal therapy. These are patients with, and I apologize that I'll use some jargon. These are patients with Gleason 7 or less prostate cancer, whose PSAs took a long time to come back, more than 2 years to come back after hitting zero. And patients whose PSAs were catching very early, whose PSA is very, very low, below 0.2. It looks like those patients do so well with radiation alone that we do not need hormonal therapy. Patients
Okay.
with more aggressive prostate cancer, with higher Gleason scores or PSAs that came back faster, those patients do need hormonal therapy. And then the next question is how much hormonal therapy? And
Yes.
it's something we're studying right now. We recommend at least 6 months of hormonal therapy, and we have a trial to see if we can figure of the higher risk patients, are there patients that need a more intense hormonal therapy regimen for longer, or is 6 months enough for everybody?
So, but is it 6 months, like 3 months before
Oh,
your
yeah.
radiation, or and then, I mean, 3 or 6 months, or 3 months before and 3 months after? How much?
Yeah, and the reason Dr. Crawford's asking that is because he knows that when we give hormonal therapy with radiation, we usually give it a few months before the radiation starts. In this setting, in the mop-up salvage setting, we don't need a ton of lead time because we don't. There's nothing really for us to debulk. These are microscopic cells, so there's no. We started sometimes a few weeks before. But I will say that, again, it's as if we rehearsed. A silver lining of using the hormonal therapy, despite hormonal therapy having side effects, the silver lining is it does not interfere with the healing and the recovery from the surgery. If we
Oh,
do radiation alone, we do radiation immediately. And if a patient just had their surgery just a couple of months earlier, or even 6 months earlier, their recovery is still going on. And when we add radiation to a recovering pelvic area,
right.
it's more likely we cause harm. But if we have that hormonal therapy, we can very safely drag our feet on the radiation. And sometimes we do that. We get the hormonal therapy started and know we can kick the can down the road with the radiation and allow as much post-surgery healing to go on as we can get away with, and then do the radiation. But we do need the hormonal therapy at least a tiny bit before, during, and after the radiation.
So let me get this straight. So we know that the therapy that the hormone therapy that we use prevents the cancer from having access to testosterone.
That's
So
correct.
it's almost as if you're kind of starving it, making the cancer as weak as possible, and then you come back and slam it with radiation. So you're trying to kill as many cells as you possibly are, or kill all the cells that may
Yeah,
be
yeah.
cancerous.
Yeah, we think that the hormonal therapy makes the radiation work better for two reasons. One is exactly what you just described. The cells seem to be much weaker when they're starved of the fuel that they need, and the cells just fall apart much more easily when they get hit by the radiation. The
Right.
second thing that the hormonal therapy may be doing is it may be helping some people by mopping up any microscopic disease outside of the radiation field. There may
Oh,
be tiny, tiny deposits of cells that we can't see. We don't know where they are, but outside of where we're casting our net. And maybe the hormonal therapy alone mops up some of them. But for whatever reason, for the higher risk patients, the combination seems to be much better than radiation alone.
okay. So now we have the patient. Let's go. I'm switching gears and jumping over to radiation,
Okay.
recurrence after radiation. Um, well, I've already had radiation. So are we just saying that starving the cancer is going to be as efficient as treating them with the hormones and the radiation? Because it
Yeah.
doesn't appear that the person who's received radiation treatment has any other, standard options that are available to them other than to starve the cancer.
Yeah, that is correct. But it's changing, which I will
Okay.
explain.
All
Um,
right. Okay.
uh, Historically, and until very recently, um, we really had no other options for our radiation patients whose PSA is rising and we know there's microscopic disease somewhere. We would
Right.
just have to rely on medicine alone, on the hormonal therapy alone, to control that prostate cancer lifelong. But in that setting, we did not expect to cure them. With surgery post, I'm sorry, with radiation post surgery, we're going for a cure. But when the disease comes back after radiation, our best our best chance was just to control the disease with medicine. And when we present surgery versus radiation to our patients, we always do mention that one advantage of surgery versus radiation as the upfront treatment is that we do have that safety net of being able to mop up anything left behind with radiation after surgery. But with radiation, we can't do surgery, and we have fewer options, but that's changing. Um,
What you said right now is a pearl that any person who's been diagnosed with prostate cancer needs to clearly walk away with. Because a lot of folks, that nuance, some of the people saying like, I don't want surgery, but if it comes back, you got more tools in your tool chest if you have surgery versus I'm going after radiation because you don't have an additional tool. I mean, I won't say you don't have an additional tool, but you have less. And so
yeah.
the question is, I just want to ask, is there, where would you put, this cancer came back, surgery versus radiation, and the PSA is going up. Where would you put the PSMA PET CT scan?
Yes, that's what's I said a couple of times things are changing, and that's what's changing. We now have we now have imaging that is far superior than what we had before 2022. The most recently FDA approved scan can begin to see very small deposits of prostate cancer um, uh, in the pelvis at levels we just cannot see with an MRI or a CT scan or a bone scan. The imaging that we relied on and still rely on for decades. And with this new ability, we can identify where the recurrent prostate cancer cells are sooner after radiation. In the surgery case, we get the PSA back so soon that even the PSMA PET scan doesn't help us because it's too early. But after radiation, when the PSA is a little bit higher, we do now in 2026 use this fancy new scan to see if we can identify where this PSA may be coming from. Where are the resistant cells? And we have another new development, which are more.
I'm just saying, we're saying okay.
Okay.
I'm saying,
the other new development is we have more sophisticated radiation technology, so we can be much more precise with the radiation. Where in the past, if we saw a spot somewhere in the pelvis, we'd be scared about zapping that spot with radiation because of all the collateral damage that we can do. We do not have that fear in 2026 because the technology has improved so dramatically.
So can you have, if you've been treated with radiation and you have the disease comes back again, are you saying that you can have a shot of radiation if it's, oh, okay. But
yeah, we have a shot of radiation to whatever lights up on that scan, and then we cross our fingers that was the full extent of the recurrence.
Now, is that like a cyber knife, or is it just the same external beam radiation or something?
It's not exactly CyberKnife. It's a similar principle. CyberKnife was one of the first technologies that did this. We now we have some technologies that are even more sophisticated that can precisely aim the beams and hit any spots that show up on scan.
Okay. So now we have a good understanding. I think everybody has a good understanding. And there's a lot of pearls in here. But the most important thing to do is have that discussion with your healthcare provider, with your team of healthcare providers. So, what question should a patient ask before making a decision about their treatment?
Yeah. So there are a number of pros and cons with the two primary forms of treatment for prostate cancer. Again, surgery or radiation, usually radiation along with hormonal therapy. Those are the two standard ways that we cure prostate cancer that's newly diagnosed and hasn't spread to other parts of the body. Once it spreads to other parts of the body, it is a different discussion. But in thinking about surgery versus hormones and radiation, there are pros and cons. I apologize if I'm repeating any of this, but it is important.
No.
One of the big advantages with surgery is that safety net, our ability to pounce with radiation very, very early if we get the first hint of a recurrence. Another advantage of surgery is, and this is for our younger patients, for our patients mainly in their 50s, is that radiation can cause cancer. I mean, we know that from, we know that from Chernobyl and in pediatric oncology, when we treat kids with radiation, when they hit their 40s and 50s, they develop cancers because radiation causes cancer. For our 72-year-old patient, that's a non-issue because it's a risk that accrues over decades. But for our 52-year-old patient, it's on my mind. Because we can cure them of their prostate cancer and they can be a perfectly healthy, active 78-year-old. And this radiation can then, all those decades later, can cause real trouble. So for our younger patients, that is another reason why we lean towards surgery. The big disadvantage of surgery is that it is not as gentle on that very, very busy neighborhood where the prostate resides. There are important nerves that run right alongside the prostate. And if those nerves get damaged in the surgery, it could affect erectile function or bladder control. Those risks are less with radiation. Those nerves do not get damaged routinely with radiation, but it is a risk with surgery. And that's an argument for the radiation. And it's an important advantage of the radiation. Another disadvantage of the radiation is we typically do recommend a course of 6 to 18 months of having your testosterone taken away, which is also there's no picnic and has its own host of side effects. Hormonal therapy is not part of surgery, at least in 2026, it's not.
So that's great. So now I want the audience to kind of let this kind of sit in and think about what we've heard today. And then I want to open the floor, whether online, virtually, or in the audience here, to have an opportunity to ask an expert in the space about recurrence of disease and how it's treated. And there was one question that came up, and I just wanted to ask. One of the patients, persons online, said they had their doctor was looking at the PSA and then comparing it to the testosterone level. Now, they didn't really get a good understanding about what's this relationship or why are you monitoring the PSA so closely after you've had treatment. Could you help us better understand what's going on in that scenario?
And this is not shouldn't be an issue with our surgery patients who don't get hormonal therapy, but it is something that is very important as we monitor the hormones and radiation patients. The patients that get hormones and radiation have had their testosterone taken away for many months. And when treatment is over and we declare victory, we wait for the body to recover. We want the body to start making testosterone again. So you get your old body back. Of course, if you're cured,
Right.
you're cured. We want you to have your old body back. And the PSA begins to uh, become more interesting when the testosterone comes back. The testosterone, again, is fuel for prostate cancer. And so we're very curious what the PSA does when there is once again fuel for prostate cancer flowing through the bloodstream. If there is any cancer left behind, that PSA may begin to skyrocket because the tiny microscopic residual cancer cells are using that newly made testosterone, that renewed testosterone is using that testosterone to proliferate and grow. And when prostate cells, whether it's normal prostate or prostate cancer, when prostate cells proliferate and grow, they make more and more PSA. So when we follow you up in clinic, we're always processing what a guy's PSA level is relative to the state of his testosterone.
So it's interesting because again, we go back to basics, following the PSA level. Wow. So
Yeah.
Jerry, you have some questions for me.
Yes.
You got to speak up a little bit.
Yes, I have a question. Someone asked, after recurrence, what kind of treatments are recommended as compared to the original diagnosis? Can I also join any clinical trials at this stage?
Yes. Oh, wow. I'm glad you asked. So this is a very active space for clinical trials because we are still trying to figure out what the ideal medical treatments are along with the radiation. And we have an interesting trial right now for patients who have recurred after surgery and who are gearing up to receive their post-surgery radiation, where we're using a new test from a company called Artera that if the story goes on too long, I apologize, but I find it kind of interesting.
No. I think everybody's listening.
So this company has a
online
product,
and here.
a commercially available FDA-approved product that uses, God help us, AI to determine how aggressive a prostate cancer is. They use the pathology, the way that they trained their machine is they showed their machine thousands and thousands and thousands of surgery specimens from patients whose outcomes they know, whose long-term outcomes they know, and the computer, the company doesn't even know how it works, I don't think. At least they haven't told us that they know how it works. The computer figured out some kind of algorithm that predicts whether someone's surgery is a surgery specimen represents aggressive disease that is going to come back, or disease that's not aggressive, or even if it comes back, it doesn't require much treatment, or prostate cancer that's super dangerous. And so in this trial, we're giving this test to all the patients. And if the test says this is not a very aggressive prostate cancer, we're going very easy on the hormonal therapy. And if this AI test says that this is a very aggressive looking prostate cancer, then we're being even more aggressive with the hormonal therapy, adding other hormonal therapy agents, or going a little bit longer with the treatment. And we're seeing if this may be a tool that helps us figure out who needs the post-surgery hormonal therapy and who may need more intense post-surgery hormonal therapy along with their radiation.
So that's important. I want everybody to recognize what was said here. Prostate cancer clinical trials are part of your treatment options.
Mm-hmm.
A lot of people don't recognize this. This is not like the end of life type treatment. It's just it's brought into being part of your treatment options. And this is extremely early. This is real early. This is like it's recurrence, and you haven't even started your hormonal therapy yet. So that's an important point. We have somebody in the audience who had a question. Oh, we got a couple of folks. Go ahead.
Yeah, I have a couple of questions. One is, what type of cancer does radiation cause? Another question.
That's a really good question. The list is very long. For patients that have, and I've seen this just a handful of times in my career, but when prostate radiation causes a cancer down the road, it tends to be a cancer of the soft tissue in the area around the prostate and the pelvis, like even the tendons or the muscles in the area. So it's the type of cancer is called a sarcoma. It's very ugly. It's very aggressive. It's very difficult to treat. We've also seen cancers of the bladder, but not typical bladder cancers. Cancer types that we don't see routinely in the bladder. It's also sarcoma-like.
So
That's
So let me ask you before I want to. Now, is there some relationship between prostate cancer radiation and multiple myeloma that you've come across?
Not that we know of. Not that we know of.
Okay.
Now, when radiation hits bone, that does put people at higher risk for blood cancers like myeloma or leukemia.
Okay.
But our modern radiation, and in this sense, modern means the past 25, 30 years, they've done a very good job of avoiding bone.
Okay. Okay.
Another question is, I see these commercials with advertising for men to get testosterone to boost their testosterone up. Is that making them more at risk for prostate cancer?
That's a fantastic question, and an important one because it's all over the place. These advertisements, and this is something we're still studying. But as of right now, we have no evidence that a high testosterone or additional testosterone causes prostate cancer. Now, additional testosterone, higher testosterone certainly can promote the growth of known, present, already formed prostate cancer. So that testosterone that they're advertising for on the radio or in television, there's no evidence that they are putting people at risk of developing prostate cancer. But if the guy already has it and doesn't know it, it could cause it to grow much faster. And so what a responsible urologist does, because it usually and should be, I know in the current commercial environment it's not the case, but it should be the urologist that prescribes testosterone. What a responsible urologist does is looks very carefully at the patient and may even do a prostate biopsy to firmly establish that there's no prostate cancer present that we can find before prescribing the testosterone.
Okay.
My final question is that you mentioned that with surgery, you can go in and mop up with radiation after. But if you get radiation, wouldn't that be mopping up so you don't need to get anything after? Wouldn't that get it all? So there's no need. No, with surgery, you say that if you miss some of the cancer, you could go in and mop up around the area with radiation. But if you get radiation, I'm saying that then there's no need for mop up because the radiation should get everything one time. Is that?
Yeah, that's generally the case, though. Down the road, we are seeing, and it's unusual, but we can see recurrences of the prostate cancer within the prostate, even though the patient had radiation to the prostate. And an interesting development in our business over the past 5 years is we are learning how to safely re-irradiate the prostate if we need to. It's something that was not on the radar screen. We would never mess with that 10 years ago. But we have a radiation oncologist who's been studying it for many, many years now. And it's something we are doing if we do detect a recurrence within a previously irradiated prostate.
Okay, next question.
Is on now? Okay.
Yes.
Okay. So I had two questions. One's a follow-up on his. So radiation can cause cancer down the road. Does that include the type of radiation I might get after surgery?
Yeah, it does. It does.
Oh.
But the risk of the cancer, of the prostate cancer, is much higher than the risk of developing a secondary cancer from the radiation. So the pros far outweigh the cons. And
Okay.
and I want to be clear about this risk of a secondary cancer from the radiation. The risk is low. The best study that we have looked at as follow-up for about 15 years. And at 15 years, the risk of a radiation-induced new cancer, one of these ugly cancers that I was talking about, the risk at 15 years in the best study was 0.3%, which is minuscule. It's almost meaningless. The problem is that we don't have good data for 20, 25, 30 years. And it may be, we're going to learn this over the next few years, but it may be that at 20, 25, 30 years, that risk does go up, which is why for the younger patients, we tend not to mess around. But if the prostate cancer comes back, even if you're 52 years old, we got to do what we got to do. That prostate cancer is much scarier than the risk of a secondary cancer.
Okay. The other question is, you said two things that seem contradictory to me, but I think I didn't understand something. One was, let's say I have the surgery. I'm having it in a few weeks, in fact. And a few months later, I have a PSA of, 0.5, 0.6, something that's still of concern. You said that at that point, you can't figure out where the cancer is because it's too small. And yet you also said that the external beam radiation can be so precise that you're likely to hit the cancer and not damage anything else. And I don't see how those can both be true.
Oh, yeah, because those are two different scenarios. So that new precise radiation is for patients who've had a PET scan, have had imaging, and we identified a spot. And typically those patients don't have PSAs of 0.05 or 0.06. They have PSAs of 1.2 or 1.8. And those are post-radiation patients. The post-surgery patients we catch much, much sooner with those tiny PSAs. And we have no imaging to detect them. And all we can do is cast a wide net with the radiation.
And that's the same PET scan that I had in December after my biopsy, after my MRI and my biopsy. They said they're taking a PET scan to determine whether I had it spread beyond. It's the same test?
Same test.
Okay, thank you.
Okay.
And who's next?
All right. What we're going to do now is, I think we got most of the questions answered, but if anybody has any questions, please, we'll try to respond to those questions, and we'll post them online.
There are a number of questions online.
Oh, okay. So
I'm happy to read them and answer them. I haven't looked, if anyone's looked through them and wants me to answer them in a different order, I could just take them in the order that I'm seeing them.
No, what we'll do is, matter of fact, if we'll take it offline and then we'll answer them and post those questions to this, the answers to the questions to the video that we post on TV, on Fin TV. Now, what I want to do, and it was important, we learned that clinical trials are part of your treatment options. And it was important because we also like in these managing survivorships, sessions to showcase a clinical trial. And I just have a nice video clip. It's only about a minute or two, just to kind of lead through, and then Jerry will post survey questions and allow you to answer the survey questions. But first, let me, and then afterwards, as we're taking the survey questions out, we may be able to answer a couple more questions. So I'm going to share.
Also, click share sound on the side. Share options up. Yeah, just on, right.
Yeah, the
You can move the box.
I can't remove the box. Okay, so this site again is Fin Trials, and if you know what your diagnosis is and you know the states that you live in, you can find out what clinical trials are in your neighborhood, in your state. So I welcome everybody, if you're interested in clinical trials, to take a quick look at this. But also what we have, if we work with pharmaceutical companies to help them present their information in a simpler format so the average person can understand it. This one clinical trial is very interesting, and we wanted to showcase this. And I think the best way to showcase this is by a simple video. So I'm going to play the video, and the name of the clinical trial is Legion 100, and it's by Synchromune. And so let's get started.
The SYNC-T solid tumor treatment platform is designed to work within the body to synchronize immune system education and stimulation using a multi-target drug and device combination therapy. SYNC-T is an investigational, novel, personalized cancer therapy that targets multiple mechanisms to empower the immune system to recognize and destroy cancer and to defend with immune memory. Depending on the location of the target, CT or transrectal ultrasound imaging can be used with SYNC-T. SYNC-T can target both primary and metastatic tumors. Once our proprietary device is inserted into the target tumor, the first step is to lyse a small portion of the tumor. This causes tumor cells in the lytic zone to rupture, releasing neoantigens into the tumor microenvironment. Neoantigens are tumor proteins that can be used by antigen-presenting cells to educate T cells within the immune system and empower them to recognize and attack cancer throughout the body. The second step is to infuse our proprietary multi-target drug into the lytic zone. The multi-target drug is designed to reverse immunosuppression and be highly immunostimulatory. Portions of the mixture of drug and neoantigens flow out of the tumor via the lymphatic vessels into locoregional lymph nodes. This synchronizes the location of the three components necessary for T-cell education, namely the patient-specific neoantigens, the multi-target drug, and the immune system components in the tumor microenvironment and tumor-draining lymph nodes. The goal is to activate the immune system and combat immune suppression, resulting in effective patient-specific T-cell education. The third step is the expansion of anti-cancer specific T cells that can recognize and destroy the cancer throughout the body. In summary, SYNC-T is a novel, personalized cancer therapy platform that has the ability to target multiple mechanisms to empower the immune system to recognize and destroy cancer and to defend with immune memory.
Is something Dana-Farber does?
There,
Last one.
I can't even, doesn't show. Okay, so clinical trials are part of your treatment options. And I want Jerry to put up the survey questions. And Mark, can you pick a couple of those questions that you think that patients need to understand before we go?
Okay, this is an important one. Before we go, what are options for cancer that recurs after salvage radiation therapy and hormonal therapy. And in the old days, like before 2022, 2023, in the old days, once the disease came back, the PSA started rising after salvage radiation and hormonal therapy. We would say that this disease is no longer curable, and we are going to manage it long term with hormonal therapy, with or without some of our newer agents. And when the disease becomes resistant to the hormonal therapy, we now have new second line and third line and fourth line treatments we're very excited about, but we're talking about a chronic disease, not something that we can get our arms all the way around. That is changing with the new PET scans and with the new forms of radiation. If we see a PSA recurrence after all of this stuff we talked about tonight, after all of the salvage treatment, we try and look for where that PSA may be coming from with the PET scan, and we are increasingly very aggressive with the radiation to try and play whack-a-mole with this thing after salvage treatment. This is new for us.
So in this case, when we start thinking about, you mentioned something that was very interesting. In prostate cancer treatment, almost we treat it like it's a chronic disease. Are we treating it like a chronic disease now, or is that something you're thinking?
In the setting that we've been talking about tonight, talking about surgery or upfront hormones and radiation, we weren't talking about a chronic disease. We were talking about curing the disease. And when we were talking about salvage treatment, we're still talking about curing the disease. Once the disease becomes incurable, we are talking about a chronic disease that we are managing, and we're getting better and better at it. In fact, when prostate cancer or any cancer becomes metastatic, it's very unusual that we can cure it. But what's changing in the cancer business is that we are turning more and more cancers into chronic diseases like high blood pressure and diabetes and coronary artery disease. We don't cure any of those things. They are chronic diseases that we manage over the course of a person's lifetime. And cancer is becoming something very similar. We need to do better about some of the side effects of some of our medicines, but we are doing a better and better job of turning this into a chronic problem.
Okay. Was there any other question that you see that?
There was a question about surveillance, and we talked about the pros and cons of surgery versus radiation without mentioning surveillance. And absolutely, there is a role for simply surveillance for a large proportion of prostate cancers. Some prostate cancers look so unaggressive under the microscope with a low Gleason score and are so low volume that we can safely watch them, and we watch closely, and only pounce with treatment, with surgery or with radiation, if and when the disease looks like it's becoming more aggressive. There's absolutely a role for active surveillance. Though I'm sorry, Dr. Crawford, you're about to say.
No, go ahead. I'm sorry.
The one thing I do want to mention is that our two gigantic active surveillance cohorts were not enriched for men of West African ancestry. The one study that looked at surveillance of men of West African ancestry was unable to show that it was as safe as the larger trials that we've been leaning on showing the safety of active surveillance. So that is an area of research that's ongoing right now, is for Black men. Is active surveillance just as safe as it is for the rest of the population? Gleason score for Gleason score, it really does look like it's as safe. For our Gleason 7 patients, though, for even our Gleason 3+4 patients that are a little less aggressive than the Gleason 4+3, we are generally not recommending active surveillance for men with any West African ancestry because of some of the inherited variants that are associated with slightly more aggressive prostate cancer.
Okay, so that's good. So men of West African descent or African descent are in that category of high risk.
Well, the reason I say West African is because we don't know much about East Africa and South African. We just don't have as
Okay.
much data. And,
Yeah,
and they're genetically very dissimilar from West
yes,
Africa.
they are. Yep. Yes. That is correct. Because I was looking at some data with Kenyan versus Nigerian, and there was a different.
Oh, yeah,
difference.
yeah. They're as far apart as Japanese and Nigerian.
Yeah. Okay. So now there was something that you said though, but after surgery, with disease recurrence, would you do active? Would that be a scenario after the disease has come back and it's starting to creep up? Would that also be an option for active surveillance?
Yeah. It is something that we would do more commonly in the past before we had these fancy scans. In the era of these scans, we really do go looking for where the recurrences are. But in the old days, when we didn't have these scans and all we had was the PSA to guide these recurrences, we would use the PSA levels and how fast or slowly the PSA is rising to decide whether we needed to use medicine. Because I think, Dr. Crawford, what you're getting at is that there are some patients whose PSAs go up after, say, surgery that's rising so slowly and looks so unaggressive that maybe we can get away with just watching it for a while before we give any medicines that have side effects. And that is correct. If the PSA is rising very, very slowly, there's no advantage to treating with medicine sooner versus later. And we do drag our feet with the medicine. There's always an advantage when you're going for a cure of treating with radiation sooner versus later.
Okay.
Doctor, can I ask you a quick question?
Yes.
When you
Go ahead.
Can I ask it?
And then I'm going to go over the survey, but go ahead.
The question is, the recurrence of prostate cancer, is it greater in men from Africa or are Black African Americans than Mediterranean or European?
So the question is the incidence of recurrence, is it greater for men of African descent versus people of other ethnic groups, European, Mediterranean, South American?
Absolutely.
Yeah, that's a great question. While it is true that men of West African descent are at higher risk for aggressive prostate cancer than any group we've studied around the world so far, pound for pound, they all behave the same around the world. So a high risk prostate cancer with a high Gleason score in a man from West Africa behaves exactly the same way as a man with a high risk, high Gleason score from China. Gleason score for Gleason score, risk group for risk group, everybody's the same. But your risk of getting the cancer in the first place, the aggressive cancer in the first place, is a little bit higher in men of West African ancestry.
Thank you very much.
Okay. Thank you, Dr. Pomerantz. So what we're going to do now is we're going to go over these the survey questions. And so the first question after this session, how clear is your understanding of prostate cancer recurrence? And what we see here is it very clear, somewhat clear, or not clear? 60% said very clear. 40% said somewhat clear. Number two, after this session, how well do you understand how doctors check if the cancer has come back using PSA results and other tests? 72% said very well. 28% said somewhat. After this session, how well do you understand which treatment option may be used after recurrence? So very well was 66%, somewhat was 34%. And at least we're getting more and more people with a better understanding of recurrence of disease and the options that are available. Number four, how confident are you that you can ask your care team informed questions about recurrence, next steps, and treatment choices? 79% said now very confident, and 21% said somewhat confident. Number 5, are you aware of how FinPath can help you better understand your treatment options? 65% said very aware, 27% said somewhat aware, and 8% said not aware. So we'll be going over FinPath a little bit more later on, but we want to introduce you to that and also expose you to what clinical trials there are out there. Did the program allow adequate time for audience Q&A? 54% said yes, 42% somewhat, and 4% said no. So again, this may be a topic that it's not maybe, it's a topic that we're gonna continue on because we can dig deeper into what treatment options are available. Would you recommend this session to others? 100%. So I don't have to go any further about that. Okay. All right. So how do you rate the speaker? Excellent, 92%. You can take that, Mark, right? Okay.
Well, thanks.
And 4% said good. And then 4% said fair. But you got an A. That's a Harvard A. Okay. Okay. Would you attend another survivorship focus session? 100% said yes. How did you feel about the session, the pace? 88% said just right. And 12% said too fast. Okay. Were you satisfied with the meeting and the presentation content? 72% were satisfied, were very satisfied, and 28% said that they were satisfied. And then let's look at who was here. 88% were prostate cancer patients. 4% advocate, and community leaders were here, and some other folks. But that was more important. I think that's the highest number of patient survivors who participated in the survey and also here. So, Dr. Pomerantz, I want to give Dr. Pomerantz a big hand, okay? And give some stuff online. And thank you very much, because it was clear that people were educated and learned a lot tonight. And then I also I'd be remiss if I don't thank our sponsors, Amgen, Bayer, the Dana-Farber Cancer Institute, because we're here at the Dana-Farber and they host us every month. Amen. Okay. Exelixis, Johnson & Johnson, Merck, Novartis, and Pfizer all play a role in making sure everyone throughout the country has an opportunity to learn these managing survivorship lessons. And I would like to close. So today's discussion reminds us that when prostate cancer returns, survivors still have options, support, and reason for hope. The key is to stay informed, ask questions, and move forward with a care team and resources you can trust. So thank you very much for attending our April session of Managing Survivorships. Goodbye, everyone.